Sure, ma'am.
Yeah, I think let us start. I will not put on my video because anyway it is not seen, ma'am. All right.
Recording in progress.
Hi everybody, this is Dr. Chitra, your mentor at StudyMEDIC and StudyMRCOG. And today we are going to be talking about the module urogynecology, and in that we will see stress and urge incontinence, the management pathways, and we will see how to interpret urodynamic charts. All right. So you have to strive not to be a success, to be rather value. So whatever you are learning for this exam, you should also be able to apply it into your clinical practice. That is what really matters. Okay. So the agenda is management of urinary incontinence, urge incontinence, and stress urinary incontinence, and interpretation of urodynamics graphs. So first we are going to see about definitions. You should be aware of what is overactive bladder, what is detrusor overactivity, and what is urodynamic stress incontinence. So overactive bladder, as they say, it is a symptom-based diagnosis. OAB is defined as urgency and or urge incontinence. It can be dry or wet OAB. Whenever it is associated with incontinence, it is called as wet OAB. Okay. There is frequency and nocturia, and there should be no urinary tract infection or any other underlying bladder pathology. Now, detrusor overactivity. This is a urodynamic observation that is characterized by involuntary detrusor contractions during the filling phase, and these contractions, they could either be spontaneous or provoked. Now, urodynamic stress incontinence. Whenever there is involuntary leakage of urine during increased intra-abdominal pressure in the absence of a detrusor contraction. So, stress urinary incontinence, it is a symptom, it is a sign, or it even could be a diagnosis. So, diagnosis you will say whenever you have made some urodynamic investigation. Now, remember one thing, that it is not very common to do urodynamic investigations. There are very specific indications. So, you will do urodynamic studies whenever you are planning surgery for any woman in which the type of urinary incontinence is unclear. She has symptoms suggestive of voiding dysfunction. There is anterior or apical prolapse. And there is history of previous surgery for stress urinary incontinence. These are the only indications when you would be doing urodynamic studies, basically because they are invasive studies, so they are not routinely done. Now, urodynamics, basically, you have uroflowmetry, there is cystometry, video urodynamics, urethral pressure profile, and ambulatory urodynamics. Among this, commonly, uroflowmetry and cystometry are the two ones which are done. Okay, they test the bladder function and also urethral function. Now, this is a graph which is showing you uroflowmetry. That means it is showing the voiding pattern of the woman. So, typically, a normal graph would be a bell-shaped graph like this. Okay, in which this is the maximum flow rate, or it is called as Qmax, and it should be more than 15 mL per minute second. And this is plotted against time, and this is the flow rate. And you get this typical bell-shaped graph whenever the volume of urine is more than or equal to 200 mL. Now, these are some abnormal graphs. As you can see, these are not typical bell-shaped graphs. So here the Qmax is very much reduced. It is 7 mL per second. And this you would typically get whenever there is some obstruction or the detrusor muscle is not contracting properly, or there is hypomotility of the detrusor muscle contraction. In this graph, you can see that flow is intermittent. Okay, this is typically seen in obstruction. Okay, so these are the two types of abnormal graphs that are present. Now coming to cystometry. So cystometry means what? It is assessing the bladder in the filling stage. This is in an invasive investigation in which catheters are put into the bladder. Okay, so there are two catheters that are put. One is put inside the bladder. It is a bilumen catheter. One part of the catheter fills the bladder The other part is to measure the pressure. And there is another catheter that is put in the rectum to measure the abdominal pressure. Okay. So about 50 ml of normal saline is put into the bladder, and then the graph is obtained. So you have to know about the bladder capacities. Okay. Now bladder capacity normally is 400 to 600 ml. The first urge to void comes at 240 ml. And whenever you are doing the uroflowmetry, then the flow rate, like we saw, it has to be more than 15 ml per second. A basic concept to understand is that you have seen this bladder here. So the pressure of the bladder, that is P-VES, okay? How do you get this? It is a combination of pressure in the abdomen, that is P-ABD plus P-VES. So in order to get P-DET, what you have to do? You have to subtract abdominal pressure from vesical pressure, or P-DET is equal to P-VES minus P-ABD. If you remember this equation, you can calculate any of the three pressures. Now let us see the graphs as they are seen. Remember, these are the filling stages. Okay, so there will be three lines on the graph. This line is showing you how much of volume is infused. The upper one is showing you the vesical pressure. This is abdominal pressure, okay, and this is the detrusor pressure. Forget about this leak for some time. So what we are seeing here is that the detrusor pressure is not increasing, but there is an increase in abdominal pressure and there is a leak. So whenever there is leakage without increasing in the detrusor pressure, it is what we call as stress urinary incontinence or urodynamic stress incontinence. Now coming to this graph. So in this graph, what we are seeing, this is the detrusor pressure, right? So it is showing contractions in the filling phase. Normally the detrusor should be quiet. There should be no contractions in the filling phase. But here you are getting contractions. Abdominal pressure is not being raised. And because the detrusor muscle is contracting, because of that, there is an increase in the vesical pressure. Forget about this leak for some time. So whenever you are getting detrusor contractions in the filling stage, it is called as detrusor muscle overactivity. Now, whenever you are having a leak, remember the leak will be marked very clearly in the graph. So at the height of the detrusor contraction, if you are getting a leak, this is called as urge incontinence. Okay, so to know whether the person is getting a detrusor contraction or not, either it can occur spontaneously. If it is not occurring spontaneously, then it can be provoked by asking the patient to cough, or you can run a tap. So in that way, the detrusor muscle can be provoked to get a contraction. Okay, so this is a very easy way in which you are going to diagnose the urodynamic graphs. So I hope it is clear to all of you. Whenever you see contractions in the detrusor muscle, in the filling phase, it will always be detrusor overactivity. Whenever you get a leak at the height of detrusor contraction, it is urge incontinence. And whenever you are having a leakage without increasing in detrusor pressure, it is urodynamic stress incontinence. Now you can have mixed incontinence, in which you will have a leak with the height of detrusor muscle contraction, and at other times the leakage will be seen without a detrusor contraction. So that would be a mixed leakage. Okay. So now that we know how to diagnose, or we know how to read the graphs, let us see what is the management of urinary incontinence. So whenever you are trying to manage any condition, the first thing is you have to be very thorough in your history, and you have to do a physical examination, basically to know what is the type of incontinence, whether it is stress urinary incontinence, or it is urge incontinence, or it is a mixed type. Now, whenever you have a patient with stress urinary incontinence, you always have to tell her what is the benefit of non-surgical treatment. Okay, because stress urinary incontinence, we know it can be managed surgically as well as conservatively. And you have to also, if there is mixed incontinence, you have to tell her what is the advantage of taking medicines for overactive bladder. Then you have to identify any predisposing and precipitating factors, like if the woman is a diabetic, if she's hypertensive, if she's on any drugs, diabetic, and her sugars are not well controlled, whether she has prolapse. So all these factors, they could be precipitating factors. So you have to identify them so that your management is proper. Now, you always have to assess the pelvic floor, because whenever you have someone with urgent incontinence and you want to advise, sorry, not with urgent incontinence, someone with stress urinary incontinence, and you want to advise the pelvic floor muscles, you should be able to know whether they are able to contract the pelvic floor muscles or not. The next important investigation, very important, is you have to test the urine for blood glucose, protein, leukocytes, and nitrites, because it's really important that you always rule out any urinary tract infection before you start management of any patient with urinary incontinence. Okay, so if the patient is symptomatic and she is already having leukocytes and nitrites in her urine, immediately send the urine for culture sensitivity, but you can start prescribing antibiotics because she is already symptomatic. Okay. Now, a woman who is not symptomatic, but she has leukocytes and nitrites in her urine, you should send the urine for culture and sensitivity, but you can wait till the reports come back to prescribe antibiotics. Any woman who is not symptomatic and she doesn't have any leukocytes or nitrites in her urine, there is no need to send urine for culture sensitivity because she is not going to have any urinary tract infection. The next important investigation is done. You have to assess the residual urine. So for this, you can do a scan, or also you can just put in an in-out catheter. But because an in-out catheter again is an invasive procedure, a scan is always preferred. And remember that whenever the post-void residual is more than 100 ml, it is always abnormal. Next is you have to inquire about the effect that her symptoms are having on quality of life, whether she is severely being affected or it is just a mild symptom that she has. Then you have to ask her to maintain a bladder diary. The bladder diary has to be maintained for a minimum of 3 days, and she has to record everything, the amount of water that she drinks or amount of fluids that she is drinking, the amount of voids that she has, whether she has incontinence or not, and make sure that you include a period of rest and a period of work pattern. So you get to know what is her bladder diary like during when she's at home and when she's at work. Now, whenever you are taking a history and you have some symptoms like the patient, she complains of persisting bladder or urethral pain, or she has already voided and still her bladder is palpable per abdomen. If you feel that she has any benign pelvic masses or she has other complaints like fecal incontinence, if you are suspecting a neurological disease, she has symptoms of voiding difficulty, or she has previously had some surgery for urinary incontinence, then be aware, because all these are indications for referral to specialist service. All right. So now that you have taken a good history, you have examined the patient, let us see what are the modalities available for treatment. In the UK or in NHS, remember, always the non-invasive things are preferred first. So first is lifestyle interventions. So you can advise the woman caffeine reduction or stop coffee intake totally. She should be drinking adequate fluids. That means 1.5 to 2 liters of plain water. If her BMI is on the higher side, more than 30, advise her to lose weight. Then next is physical therapies. So you can offer pelvic floor muscle training for 3 months for women, those who have stress urinary incontinence or mixed urinary incontinence. And this PFMT, she has to be doing 8 contractions 3 times in a day. Okay, remember, for 3 months. And if this is beneficial, then she can continue doing the exercises. Now, electrical stimulation, whenever you are doing PFMT, it is not routinely used, okay, or it is not routinely used in combination with PFMT. You can consider it if the woman, she is not able to actively contract her pelvic muscles. Then you have behavioral therapies. This is basically for urge or mixed urge incontinence, mixed urinary incontinence. Okay. So this is bladder training, which is given for 6 weeks. Now, bladder training, if this is not satisfactory at the end of 6 months, if the woman is not satisfied that her symptoms are relieved, you can add some drugs for treatment of overactive bladder, especially if frequency is a major concern. Then the other modality is neurostimulation. Remember, whenever you are doing any invasive procedures, you will first consult the local MDT. Neurostimulation is offered for overactive bladder, and transcutaneous sacral nerve stimulation is the one that is not offered these days. You can offer PTNS or percutaneous tibial nerve stimulation, and this also is offered only if the woman, she doesn't want botulinum toxin. Okay. Use of absorbent container products, urinals, or toilet aids. These are not routinely offered. They are offered only as a coping strategy. And even catheters, like specific indications, if you are not able to achieve continence at all, any patient who is bedridden or post-surgery, only for these women, catheters are indicated. Next, coming to invasive procedures. So for overactive bladder, you can offer intravesical botulinum toxin. You can give percutaneous tibial nerve stimulation. You can offer augmentation cystoplasty or urinary diversion in cases which are refractory to treatment. For stress urinary incontinence, the surgeries that are available is colpo suspension, either open or laparoscopic. Then you have autologous rectus facial sling, or you can offer intramural bulking agents. Let us see first the management of urge. Okay, so in this, we have already seen what is the conservative management. Let us come to bladder training. Okay, so what is the aim of this bladder training? It aims to regain control of the bladder. So you have to tell the woman that the time when she goes to pass urine, it should be the time when she wants to go and not when she gets the urge to go and pass urine. So for this, you will offer her some distraction techniques. Like whenever she gets a detrusor muscle contraction, she can start counting down from 50 to 100, or she can start reciting alphabets. And then at the end of that, she will notice that the detrusor muscle contraction has passed. She is no longer having the urge to pass urine. And in this way, slowly she can increase the timing between voids from 15 minutes to 30 minutes, from 30 minutes to 1 hour, from 1 hour to 1.5 hours. So by the time she has control, like she doesn't have to pass urine for 1.5 to 2 hours, that means if she is able to do that, the bladder training is helping her. Okay. If bladder training is not helping her, then you can use some form of drug therapy. The drugs commonly used are antimuscarinics, but these are not very accepted by the patients because there are a lot of adverse side effects. Like there is dry mouth, constipation, blurred vision, somnolence. Okay, and remember that these drugs, the commonest one is used as oxybutynin. You have to use it with very much of caution in old, frail women. So for women, those whom you cannot give the oral drug, you can use the transdermal preparation. And you have to tell these patients that it takes a minimum of at least 4 weeks to see the effect of the drug. Okay, so after 4 weeks, you can have either a face-to-face interview or you can have a telephonic conversation and ask them how they are doing. If they are accepting the drugs, they can continue the drug. Okay. Women for whom nocturia is a concern, desmopressin can be used, but use it in caution with elderly, those who have cardiac disease or those who have previous hyponatremia, patients those who are on diuretics. You have to be very careful when you are using desmopressin. Remember to monitor electrolytes at 1 week, 4 weeks, and 6 months whenever you are using desmopressin. Another new drug that could be given is mirabegron. So this is a potent and a selective beta-3 adrenoceptor agonist. Remember, use it with caution in women, those who have hypertension. Okay. So these are the drugs that you could be using for women, those who have overactive bladder or those who have urge urinary incontinence. Now, if the woman, she is not responding to your bladder draining, drugs are not helping her, the next step of treatment is botulinum toxin type A. Remember, this you have to do. You will offer her only after a local MDT review. Okay. The initial dose that is used, it is 100 units. And you have to do a lot of counseling for these women. You have to counsel them that the relief of symptoms, it could either be complete or it could be partial. Sometimes they can have urinary retention and they need to do a clean intermittent self-catheterization. Okay, if they are not able to do that, you can offer them temporary indwelling catheters. Okay, and another thing that you have to counsel them is that if the symptom relief is good, but the relief of symptoms is for less than 6 months, then you can increase the dose to 200 units. If the symptom relief is good, lasts for more than 6 months, but afterwards the symptoms are recurring, you can give another injection of 100 units. Okay, and remember, for women those who you have offered botulinum toxin, you have to have a face-to-face or a telephonic review within 12 weeks of treatment. Next is percutaneous sacral nerve stimulation. Tibial nerve, sorry, this is tibial nerve. Okay, so remember that it is offered only whenever there is no response to previous modalities. You have to tell the patient that there is a risk of failure. There has to be a long-term commitment. She needs to come for regular follow-ups. There could be need for surgical revision, and it is associated with a lot of adverse effects. The other surgeries that can be offered for women, those who have urgent incontinence with overactive bladder, so they could be offered augmentation cystoplasty. Now, whenever this is done, remember, it is a one-time procedure. It's going to be there lifelong. The adverse effects or the side effects, you can have bowel disturbance, there is metabolic acidosis, there is mucus production because a part of the bowel is put inside into the bladder. So the mucus production is there that could be retained into the bladder. Then there is a risk of urinary tract infection and also urinary retention. And the follow-up that is needed, it is lifelong. If nothing works, then the last resort is urinary diversion. For any person who has undergone any type of surgery like augmentation cystoplasty or urinary diversion, remember to provide lifelong follow-up. So that is the management of urgent incontinence. Now coming to stress incontinence. So the first is conservative therapy like pelvic floor muscle training. We saw for 3 months, 8 contractions 3 times a day. Weight loss if BMI is more than 30. Then the first line of surgery as advocated by NICE guidelines now is colposuspension, also known as a Birch colposuspension. You can either offer it as an open or a laparoscopic procedure. The second is autologous rectus facial sling or retropubic mid-urethral mesh sling. If none of these work, then intramural bulking agents, remember these are permanent, they could be offered to the patient. You have to counsel these patients that whenever you are giving intramural bulking agents, repeat injections may be needed. But the evidence for this is very limited and they are less effective than surgical procedures. Artificial sphincters are not the first line of treatment and they are not offered unless surgery has failed. A few important things to remember about this mid-urethral mesh sling is that these are permanent implants and complete removal might not be possible with them. So, and the device that you are using, it should be manufactured from type 1 microporous polypropylene mesh. Whenever you are putting in this mid-urethral sling or the mesh, do not use the top-down approach or do not use single incision suburethral short mesh sling insertion. And also do not offer any transobturator approach unless you have specific indications, like there is a previous pelvic procedure, in that only you will offer transobturator approach. So this was the management about urinary incontinence and how you are going to interpret the urodynamic graphs. Let us see a typical question that might appear in your exams. So you have this 50-year-old woman who presents with urinary urgency. She has frequency more than 10 times during the day, 2 to 3 times, no urge or SUI. A filling cystometry is done and the graph is shown below. So what is your diagnosis from this? So if you see here what is happening, this red line, this is the detrusor pressure. So detrusor muscle is showing contractions. Then this is vesical pressure. Again, because detrusor pressure is increasing, vesical pressure is also increasing, but abdominal pressure is not increasing. So if you look only at this graph, obviously, because you are seeing detrusor muscle contractions and there is no leak, you see her symptoms. She has urgency and she has frequency. So the diagnosis here is detrusor overactivity. Okay. Now, another question that could be asked is, you have a 32-year-old woman who has had one child and she has been referred by her GP with 1 month history of urine leakage on running and exercising. She has no urgency. Frequency is 4 to 6 times during the day, once at night. That means no nocturia. She has no prolapse, no bowel symptoms. She had a spontaneous vaginal delivery 2 months ago and she is currently breastfeeding the baby and she is planning for another childbirth in about 2 years. On examination, BMI is 22, general and abdominal examination is unremarkable. Vaginal exam showed no evidence of prolapse. Okay. Cervix is healthy, uterus anteverted and normal size with no adnexal masses, and there is no demonstrable SUI. Her urine analysis was normal. So what is the most appropriate next step in her management? Either you will do urodynamics, you will offer her bladder training, you will offer her supervised pelvic floor exercises, you will give topical estrogen therapy, or you will offer her treatment with duloxetine. So basically, this woman, she has only urinary leakage, and that too only on running and exercising. That means whenever she is doing some physical exercise, at that time she has urinary incontinence. There is no frequency, there is no urgency. So in all likelihood, she has stress urinary incontinence. We saw that whenever any woman has stress urinary incontinence, the first thing that you would do for her is conservative management. Okay. So you would tell her to lose weight, but her BMI is 22. So that means her weight is on the normal side. She doesn't need to lose weight. Then after that, the next thing is supervised pelvic floor exercises. So here it is, yes, it is supervised pelvic floor exercises. And one more thing that you have to keep in mind is that whenever you have any patient with SUI, you will normally not advise surgery initially, and especially any woman who has not completed her family, surgery is not the first line of treatment. You will always offer her conservative management. After she has completed her family, only then, if necessary, you will offer her a colpus suspension or a sling procedure. Because what happens is, after the surgery, if the woman becomes pregnant again, then all whatever you have achieved by the surgery, that again, by the weight of the pregnant uterus or your surgery, the advantage of surgery will be lost. So any woman who has not completed her family, presenting to you with stress urinary incontinence, always first offer conservative management in the form of supervised pelvic floor exercises. Now, another typical question is, you have a 50-year-old who has undergone surgery for SUI and she has come back again with complaints of incontinence while she is coughing. So what is the next management plan for her? Pelvic floor muscle training, urodynamics, colpus suspension, or sacrocolpopexy? Sacrocolpopexy is out of question because she doesn't have any wall prolapse. Okay. So PFMT, urodynamics, or colpus suspension. Among these, you have to choose. Obviously, it is urodynamics because she has already undergone some form of surgery. And we saw that what are the indications to do urodynamics? Whenever there is a previous history of surgery for stress urinary incontinence and the woman comes back to you again with any signs and symptoms, then you can get urodynamics done. Okay. Now, another lady, she presents with urgency, frequency, nocturia. She has both urge and stress incontinence. So, what is the most appropriate management for her? You will do urodynamic studies, offer her PFMT, you will monitor her fluid intake, you will offer her bladder training, or you will offer her PFMT plus bladder training. Now, this woman, she has symptoms of both urge incontinence and stress incontinence. So, that is why you will offer her PFMT as well as bladder training. Because what they have said in the guideline is that whenever you have women with both these symptoms, you will take a very thorough history and you will start initial treatment based on this basis. So whenever you have mixed urinary incontinence, you will direct treatment towards the predominant symptom. Okay. And whenever you have stress incontinence as the predominant symptom in mixed urinary incontinence, you will discuss with the woman the benefit of non-surgical management and medicines for overactive bladder before you are offering surgery. Okay, so if you have a woman with both symptoms and you have the option of PFMT and bladder training in which no symptom is predominant, you will offer treatment for both. That means PFMT for stress urinary incontinence and bladder training for overactive bladder. Okay, so these are the typical type of questions that would be appearing in your paper. I hope this discussion was of help to you and it will help you to solve your questions. So thank you for a very patient hearing. I hope that this video was helpful to all of you, and good luck to all of you for your exams. Do well. Okay. Good luck once again. Bye-bye and thank you and take care.